especially related to reporting, just to try and showcase our progress upwards. So I'm happy, and mine is to say a big thank you to all of you, and also thank you to Palladium team for equally creating time and also prioritizing this process. So yesterday we did cover some milestones, and there were questions that actually were raised. And from what I gathered from a colleague, Kyoko, is that there are a few things that had been packed because decisions were not made extensively. And I think today, therefore, today offers another opportunity to revisit some of the things which were not fully addressed yesterday. And also hoping that you guys also managed to create time to relook at the system again at your free time, and that you equally have more questions to Palladium, because they're the ones who developed this system. So please, we need to ask them as many questions as possible, so that at implementation, you're able now, all of us, to be at the same page. So in place, I don't want to take much time, because I know again today we will attempt, or rather Palladium will attempt to look at some of the forms, the data collection forms, and also try to relook at the reporting. And those two are equally very important. So I will hand this over to Bernard to now again take us to the agenda of the day. I don't know whether he wants to be, I think, Bernard, I think you should prioritize first the forms, and then now you can now take us to the reporting. Over to you, Bernard, and thank you all of you for, and also please, that we know who is here, take advantage of the chat box and register yourself. Tell us your name and the organization which you represent.
Okay, thank you very much, Shem. I think we'll just start off. We are starting at 2:10, so we are we are about 10 minutes late. So as Shem has put it, we are going to look at the KP encounter forms. Some of them, I'm sure maybe we might not go through all of them, but if time allows us, we will do as much as we can. Then after that, we'll be looking at the KP reporting and how to generate those from the system. Before we begin, before we start, maybe a little housekeeping. Yesterday, I think we were having a lot of interferences when it comes to guys who are not muting. So I'll sincerely request that if you are not asking questions or talking, you kindly mute your mic so that we can have a peaceful training. And I'll share the link. The link still remains the same, .84. So I'll share that in the chat window. So that is the Kenya EMR instance that we are going to use right now. So if you look at your chat window, I've just pasted it right there. So you can access that. So then we again do it the way we did it yesterday. We go together. Feel free to log in with your credentials that you had created for yourself yesterday. And again, as I told you yesterday, the training will be recorded. So for those who maybe for a reason or two may not be able to follow today, you'll still get the recording on our official YouTube channel. Feel free to log in, subscribe as well, so that you can get similar videos in future. As for the introduction, I think Shem has already spoken to that. Please self-introduce in the chat area so that we know our participants for today. Okay, so having said so, I would like to share my screen, then we start off. So I'll just need one person to confirm if my screen is visible.
Yes, it is.
Thank you. Yeah, so I guess you remember this screen for those who were with us yesterday. This is the Kenya EMR login screen. Yesterday, we were able to create our login credentials. So everyone here now knows how to create a new user in the system. Everyone knows how to use that particular credentials to log into the system. Then after that, what we did yesterday, we created the credentials for a peer educator. And we had agreed yesterday that the workflow requires that one, a peer educator must be created first as a user, must be given the login details and the password so that they are able to log in. Then we also agreed that the peer educator must also be registered in the system as a client. And when we are registering as a client, we don't create a new one. We simply we simply use the existing user and make them a client. So we don't start we don't start afresh. So that is very important so that the peer educator can have two roles. One role is a user. They can use the system to provide services and provide commodities to a client. And two, the system can be used also for them or on them to receive the services that they need to receive as the KP group. Then again, what we did again yesterday, we were able to create a client. We registered a client in the system. We were able to link this client to the peer educator, and we were able to illustrate how to complete the peer calendar. I think we did that. Then I think what was remaining now was to register this particular client in the clinic so that they can start receiving additional clinical services. So that is where we are, and that's where we're going to begin from today. So if you are able to log in, kindly just log in so then we can do this together. You can search for your patient. I'm sure you can remember the name of your patient, your client, I mean, that you had created yesterday. Okay. So I just need like two confirmations if two people have been able to log in successfully in the system.
Yeah, to log in.
Any other person who has logged in?
We are in.
Okay, good. If you have challenges with your login, please just go to this text area and let us know. Okay, I've not seen any complaint on the chat area, so I believe all of us have been able to log in. So let's go together. So the first step, as I said, this is the dashboard. This is the first screen you see when you log into EMR. So when we want to proceed, we have to click home. Okay. Yeah, so I think the username and password has been provided in the chat area for those who are unable to log in. Okay, so at this point, we need to go to the KP provider because at this point, I assume that you know the client you created yesterday, so we're just going to search for that client. Then we do the clinical enrollment. Then we start looking at the available clinical forms. So I'll click on KP provider. Please do that as well. So you can click all. Which patient do you want to search for? Just click on all then type the name of the patient that you had created yesterday. Note the peer educator. Please don't get the peer educator. We had already finished with the peer educator. We are on the patient that we had created yesterday, the client that we had created yesterday. So mine was called Susan Kerubo. So I want to search for her. I can see Susan Kerubo is 26 years. This must be her. So that's it. Yeah, so up to that point, who is with me up to this point? Who has successfully searched for his or her patient, client?
I have.
Thank you, Samuel. Who else? Only Samuel is here.
Hello, we are here. I've found mine successful.
Okay, good. So, so this is the KP homepage for this particular patient. So this is the KP profile for this particular patient. And in this particular page, you're able to see the summary about this particular KP client. So you'll see the peer contact, okay? You'll see the peer educator that is that this client is under. You can see the vitals. Though we did not fill the vitals, maybe we need to do that. And also you may see the date that this client was enrolled into KP program. So I think first we need to, I think it will be injustice if we don't do the vital at this point. So let's just do the vitals because we believe this client has visited a health facility. So you can click on the plus. There is a plus somewhere here. So click on that. Then the vitals window will appear. Okay. Now the date should be the date when you had checked this client in, and the date that you had checked this client in is indicated here. If you can see the section I'm highlighting on the right hand side of the screen, there's a section written current visit outpatient since some date. So this date is the date that you had checked in this client. So this is the date that the client had visited the facility. So when you are coming to this date, you need to change it to reflect that same date. So I'll change mine to be February 6th. The reason for this visit maybe is for clinical. Okay. Joe, kindly mute. So the temperature, we'll enter the temperature, pulse rate, the BP, respiratory rate, oxygen saturation, if at all you have all those readings. Then other recordings will enter the weight of the client. So maybe the client is weighing 78, maybe the height is 172 centimeters. Then the system automatically calculates for you the BMI for this particular client, so you don't need to calculate that. There is the provision for MWAC and there's provision for LMP for female clients. You simply click enter form to save these details. Again, I need 2 people who have successfully entered the vitals.
Done.
Confirmed, done.
Thank you, Kennedy and Victor. Okay. Yeah, thank you, Paul, as well. So I believe that is how you capture vitals, not only for KP, but for any other visit. The process of capturing vital is the same across the entire system. Okay. So let's now, let me draw your attention under the forms or the services that are available, the encounter forms that are available for a KP client who has not been enrolled into the clinical section. So the only services they are eligible for is peer overdose reporting tool. They also have a referral form. There is the TB screening form and the triage, which we already completed already. So these are the only forms available for this particular client. So for instance, we could look at the peer overdose reporting tool. So let's click on the peer overdose reporting tool and see how it looks like. So most of these encounter forms look pretty much as they look on paper. It's just that this one is on the computer screen. So I think you understand these variables more than I do, but I'll take you through how to fill these forms. So for instance, the first one is physical address where the overdose happened. So that is, you know what to enter there. So you could say maybe it happened in a particular village or a particular hotspot or whichever area. Then, so I'll just insist on this. So the date, enter the date when it happened. Enter the date when this happened, the overdose happened. Maybe it happened on 7th. Is this a new incident? Maybe it's a new one. Name of the hotspot. The type of site. My site was a bar with the lodging. So if this drug naloxone was provided, you say yes. Specific drug use, choose any that maybe is provided. Then you write the remarks. So this is a text area you can type in as much as you want. And the outcome, maybe the client has been referred. Then you specify where they have been referred to. Okay, then reported by somebody. So this is reported by this person. When? So the date remains for me, I said 7. And if at all there is a witness, you capture the witness, then you enter form. Okay, so I'll just enter that form. So one thing I want you to see is that we have two sections of this particular area, the quick access area. We have a section for the forms that are available, like the referral, the TB screening, the triage. Then here below, we have a section for the completed encounter forms. So for all the forms that shall have been completed for this particular client on this particular visit will be dropped down here. Okay, so very quickly you can be able to tell how many, which forms or which services a client received by simply looking at the forms that were completed down below. Should you like to edit anything on the encounter forms, you simply click on that form, whichever encounter form it is, you simply click on it and you can review what is there, or you can just click edit. So you are able to see the form one more time with all of the details that you had pre-filled, change whichever you want to change, then you save. Okay, so that is how we edit any form, and that is how the system can be able to group for us the forms that we have completed for a particular encounter. Okay, so up to this point, we want to enroll, we have to enroll this particular client in the clinic. So we are going to click on the clinical enrollment so that we can get additional encounter forms that will enable us to provide additional services. So I want us to click on the clinical enrollment button under key population section. So more people are logging in, so our server is slightly taking long to respond, but it will just come. Okay, so here we have the form. Here we have the clinical enrollment form. So again, as I said, be very careful with this date. Be very careful with that date because it takes the current date. So if you are doing the retrospective entry, if you are doing the back data entry, you realize that if you don't change this, then all your records will read the current date, which again will be erroneous and wrong for your reports. So check this date, take it back to where the correct date is. So mine was in February. So I'll still go back to February 7th. Okay, that's the date I'm enrolling this client in, no, 6th, not 7th, sorry. That's when I'm enrolling this particular client in the clinic. So the first question here is whether the patient has been contacted by a peer educator. I'll say yes. Do you have a regular and paying sexual partner? I'll say yes. Please fill this with me so that we submit together. Which year did you start sex work? So you realize this is picked from what we had entered when we were filling the contact form. So this is pre-filled for us, okay? Then we go to the next one. Ever experienced any sexual violence? Maybe no. Experienced any physical violence? Maybe yes. Have you ever been tested for HIV? Either yes or no. If it is no, then the next question pops up. We are asked, are you willing to be tested for HIV? But if you say yes, then you have a whole lot of questions to respond to, like what kind of test they did last time, whether it was rapid HIV testing or HIV self-test. So in my case, I'll say yes, and I'll choose rapid HIV test. Would you like to share your last test result? Yes, I tested maybe negative. Are you willing to be tested for HIV? Yes. Then in case of how could we contact you? Maybe I'll say yes. And then how would you like to be contacted? I'll pick maybe through a phone call. So that means the client is willing to provide the phone number. If at all there is a body name, then we provide the body contact information and the mobile number. So we can say maybe the body name is Mary. Then the phone number is maybe something. Yeah, so that's it. So this is how we complete this particular form, and this is how we register. We enroll a client in the clinic. So at this point, I'll enter the form to save it. I thought I'd already filled this. Yeah, sorry for that. I think the server is getting a lot of heat. So let's just quickly fill this. I don't know if anyone has been able to save successfully. Because once you save, the next thing you are expecting to see is to have the list of additional forms here. And I think for some reason, because of the sheer numbers, the server is misbehaving. So could someone confirm to me if you are able to see additional forms?
Yes, hello, Bernard.
Yes.
Yes, I have additional forms.
So that means you've saved successfully.
Yes,
I'm waiting
yes.
for everyone else. I'm waiting for everyone else to save so that I can save last. I think the server is receiving so many requests. So kindly, if you have not saved, please save so that I can save after you. Good. So I also saved finally. So as you can see, I have additional forms here. So we are under the community outreach, we have the peer tracking form, we have the referral, the clinic tools, we have TB screening, we have STI treatment, we have the depression screening, we have the healthcare worker overdose reporting tool. The next one is alcohol abuse screening tool and the clinic visit form, okay? Then under program level tools, we have violence reporting form. In other tools, we have KP diagnosis, gender-based violence, and PrEP treatment verification. So we have all those available. So I wouldn't really go through all of them, but maybe we could pick one each under each section. So for instance, I want to pick the peer tracking form. Let's do a peer tracking form. Okay, so we'll enter the encounter date. So the encounter date, mine remains February, maybe 7th. Tracking attempted, yes or no. If it is no, then you only give the reason why the tracking was not attempted. So these are skip patterns for validation purposes. So if you say no, you only state why it was not attempted. If you say yes, then you provide the tracking details. So I'll say yes so that we can go the long way. So then you see how the form looks like. The attempt number, is this the first attempt? Is it the second attempt? Yeah, so maybe I'll say the first one, which was done on 7th. It was a tracing by, let's say, physical or phone. The tracing outcome, the client was reached. Was the final outcome reached? No or yes? So the tracing outcome status, found. Status in the program, maybe it's active or lost to follow-up, whichever is applicable at that point in time. So mine, I'll say defaulted. And the source of information maybe is the KP himself or an informant. So depending on who you receive that information from, you select the appropriate option. Then at that point, you save. So I'll save that form. So that is how the peer tracking form looks like. Then under clinical tools, we can pick a clinical visit. I think I want to go for the clinic visit form. Okay. So this is how the clinic form looks like. It's a pretty lengthy form. So let's try and fill it. Okay, so you realize the date is the date that I checked in the client. So the type of visit maybe is initial visit. Reason for visit, maybe asymptomatic. Then service delivery model is static. You can select which one is applicable. Then under the clinic visit form, so we look at the services that are available and check whichever we have screened. Then we specify the screening result and the support we have provided, and we specify whether there is any referral or not. So for instance, if we have screened for STI, we'll say yes. Again, before we continue, any field that is marked with a red asterisk means a required field. So you cannot save that form without filling that particular field. So I just want to throw that out there so that you know sometimes you may save and you're unable to save. You may click save, but the form is unable to be saved simply because you skipped a field. So anything marked with asterisk requires that you have to really complete it. So all the services, as you can see, all of them are marked with red asterisk, except for cervical cancer. That is not very, might not be required for male clients, and the family planning as well. Okay, so STI screened yes, the screening result is negative. So if it is negative, there's nothing more we need to do. All the rest of the fields are disabled, okay? The same goes for maybe we screened for TB, yes. Screening result is negative, then the rest of the fields are supposed to be negative. Okay, so we can pick again alcohol and drug abuse. We could say yes, it was screened, but this time we say it is positive. So if it is positive, then the treatment and support is enabled, so we can specify whether we have provided any support on that. So we could say, yes, we have provided. Have we made any referral? Maybe no, or yes. If yes, we specify the referral that has been made. Okay. We can screen for violence. So it will force us, before we save this form, to specify all the screening we've done and the ones that we have not done. So like these ones I've not done. So PrEP, I've not screened for PrEP. I screened for violence, risk reduction and counseling. I provided that, it's not eligible. Family planning, yes, may be eligible, and they have it ongoing. Mental health, yes. Depression unlikely, so not supported. Okay, then we go to the HIV testing section. So this section is where we'll kind of get the details about the HIV status. So setting of the last HIV test, maybe never tested or universal HTS. So maybe you could say self-testing, if that is the option that, the response that we get. Self-reported status, maybe negative. Cancelled, yes. Tested, maybe yes. Frequency of test, maybe initial. Have we provided the results? Yes. The testing result maybe is negative. Then we don't need to link to ART or facility. So you could see those ones remain disabled. But if I say positive, so if I say positive, yeah, if it, sorry, so if it is positive or non-positive, then we have the links to ART, yes, then we specify the facility. Though I was hoping that if I click positive, I should also get the same. That looks like a small validation glitch, but when I say positive, I'm supposed to be able to link this patient. So in this case, the client is negative. Then we also get to the self-testing section. So HIV self-test, education or demonstration, maybe yes. Number of HIV self-test case given for self-test, maybe they were given, the client has been given 2. Self-tested for HIV, maybe yes. But at this point, no, I'll say no because of time. So then the rest of it, I'm unable to fill. But if I say yes, then I'll be able to specify the date the self-test was done. Maybe February or January somewhere. Maybe it was done maybe on 5th as initial, and maybe it was reported negative. If it is positive, then I enter the details for the confirmatory HIV test. I specified the name of the facility where it was done, whether it is on-site or off-site, and I specify the RT linkage details. So in this case, I'll just say negative. All right. Then the next section is counselor's name and date. So we'll specify the name of the counselor. So we can say the date of the counseling, specify the date. The next section is the care and treatment section. So you can see the rest of that section is grayed out, it is disabled for the simple fact that the client tested negative. So the client is not HIV positive. So we don't have any, we don't need to enter any details under this section. So that's why it is grayed out. So other services, maybe condom demonstration, maybe yes, abortion, post-abortal care provided, maybe no, referred, maybe no. Commodities given, maybe male condoms, somebody has been given 10, female maybe say a similar amount, maybe lubes given maybe 5, maybe needles are not given because my client is not injecting drugs. Under PEP, I'll say no. Then the type of exposure is grayed out because I don't need to specify anything. Linkage to psychosocial support, maybe no. Then if at all there's any clinical notes here, you could always type and type and type as a clinician. You can always make the box even bigger and keep on typing as you wish. Now we are going to specify the next visit date. So maybe the client is supposed to come back in March 11th. Then the name, the clinical clinician sign off. So clinician is the date of this particular encounter remains my February. Okay, a very long form. I believe you have been able to fill it all the way. Can I get a confirmation if someone has finished doing this? Anyone who has completed the form?
Yes, it's done.
Thank you. All right. So you could see the form, the clinical form is also, the clinic visit form is also dropped down here because we've completed it, and we are able to open it, see what we filled, and we can even delete the form if we don't want it, maybe because it was not supposed to be filled for this particular client, and we can also edit that particular form. Okay. Yeah, so I don't know if we need to fill in any other. I think the rest I would just leave them up to you at your own time. You could go through and fill them. The server is up 24/7, so it doesn't matter what time you want to complete these particular forms. You'll be able to do so at your time. But generally, that is how we complete the forms for KP, and that is how the forms look like in the system. So I don't know, before we transition to, yes?
Before you go on, I was trying to save my clinical visit form.
Yeah.
And the place of commodity distribution. Like I inserted 0. Like there were no female condoms given to this person because he's maybe a male sex worker. And that 0, when I'm trying to like enter the form, which is I'm getting the prompt message that please fix that error. So I don't know what the problem is. It's not accepting zeros. And maybe we are not giving condoms.
So that's very true. That's very true. So for the service you didn't provide, or for the community you didn't give, you don't need to enter anything into that field.
Okay.
Because you didn't give it. So just leave it blank. Don't enter 0, and it will save.
All right. All right. Thank you.
Okay. All right. So at this point, maybe I don't know if I want to bring in Shem for 5 minutes for a quick Q&A on forms before we transition to the reporting. So Shem, if you are in, kindly lead us in the Q&A. But before you take it up, I think somebody, Kennedy, who was, let me post this to the general public. Yeah, so Kennedy Uko is suggesting the following forms: the clinician module, depression and violence reporting form. Depression and violence reporting form. Because I'm seeing there is violence reporting form under program level tools. Yeah. So I don't know if Kennedy Uko, if that's the same form you mean.
Yes, Bernard. So the following forms are not available under clinician module. So we are just proposing if they can also be made available on the clinician module.
So where clinician module, you mean on the HIV care, under
Yes,
HIV
yes,
care?
yes, exactly.
Oh, okay. I think then that one will be guided by Shem and the team, whether that needs to be included on the clinical, on the other side of clinical care.
Okay.
Okay. All right. So Shem, you may want to take it up. I think you have 5 minutes for the Q&A before we transition to reporting. Or Kyoko, if Kyoko is available. Anyone from NASCO who is on the call? Okay, so maybe I think we can have the Q&A session after the next session of reporting. So at this point, I want to hand it over to my colleague, Kennedy Obutu, who will take us through the reporting section. And I think what we are going to see is not only how to generate KP specific reports, but generally how to generate reports from Kenya EMR as a platform. Okay, so I want you to look at it as how to generate reports, but then we are going to narrow down on how to generate the KP specific reports as well. Yes, so Kennedy Obutu, you may take it from there and take us through the reports. Thank you very much.
Okay, good afternoon, everyone. Thank you, Bernard, for that recap and also the session on KP forms that can be filled for the KP clients. I'm going to take us through the reporting component of Kenya EMR, and then narrow down to the reports that are available in KP. So let me just share my screen. Okay, are you guys able to see my screen? Yes, are you able to see my screen?
Yes, but you can enlarge it. Please maximize.
Is it visible? Can you see it now?
Yes, we
Yes,
can
we are
see it. I can see it.
Yes. Okay, that's fine. So when you log into Kenya EMR, as Bernard had taken us through, we have several modules that are available for different functions. And I'll just take us through the reports module. As you can see, from my top right, there's a report module there that is used for extracting all the predefined reports that are available in Kenya EMR. So if you want to pull any report from Kenya EMR for any service area, that is the module that you use. So quickly, let's go to reports. When you click on that, are you able to see?
Yes, we are able.
Okay, nice. So as you can see, we have different tabs containing different kinds of reports. And if you look at under common report that is there by default, we have the left and right section where we have the indicator, and then we have the patient follow-up reports. So on the indicator section, we have the aggregate reports, And then the patient follow-up reports, we have the patient level whereby you can be able to see the clients, the patient level reports where you have the client details in form of line leads. So that is what you need to take note of. So we have the common reports that are available that you might want to go through later on. We have the cohort analysis reports where we have the patient follow-up reports, different cohorts. We have under HIV, we have the indicator and the patient follow-up reports where we get our CQI reports, and then the patient level registers and line lists that are available. We also have reports for TB in terms of line lists and registers. And then we also have reports for IPT. As you can see, we have three types of reports for IPT. The MCH mother services, if in case you offer the services after doing your entries, you can be able to get your reports by just clicking on the respective reports, specifying the period you want the report, and then you get your report from KPIF. We also have OTZ reports. We have three types of reports, one for indicator and then the patient follow-ups. That is OTZ register and patient currently on OTZ. Then we have also the OVC report that will give you the patients who are currently on OVC if you offer the services.
I can't see all those reports you are saying. I can only see the window with the setting tabs on the wall.
Settings.
I can't see those OTZ or VC.
Are you seeing the KPIF screen?
Yes, but I can't see those OVC.
Okay, which screen are you seeing?
I'm seeing this screen from registration to developer. The home.
You can project your screen from your end.
I'll do that.
Is it visible?
Yes, it is.
Hello, Kennedy.
Yes.
Yes, I think what Clifford was saying, we can only see the home screen, and you were talking about the reports. So he was asking, we are not seeing the reports, like the list of the reports you are talking about.
Okay, are you seeing the reports page?
Yeah, there's the reports. Huh? The tab for reports or what?
Yes.
Yes.
When I click on cohort analysis, are you able to see?
No.
Okay, let me just stop and reshare again.
Yes.
Are you able to see my screen?
Yes, yes. Now you can
Yes,
see.
you're able to see.
When I click on HIV, you're able to see the indicator and patient follow-up reports?
Yes.
Yes.
Okay, nice. Okay,
Nice.
so those are the available reports that we have under HIV. And then I talked about the indicator and the patient follow-up reports, whereby the indicator reports give you the aggregates, and then the patient follow-up reports give you the patient level in terms of line lists and registers. We have under TB, these are the patient follow-up reports that are available. If you offer the service, you'll be able to get your reports after capturing the information in the respective forms available for TB clients. IPT the same, we have 3 patient follow-up reports. We have also MCH mother services. If you offer the services, you'll be able to get your reports. OTZ, we have 3 reports, 1 for indicator and 2 for patient follow-up reports. OVC, we have one report for OVC, that is the current the patients who are currently on OVC. Then we have the MCH child services. We have the warning indicator and patient follow-up reports. You can be able to go through these later on, just showing you the available reports in Kenya EMR. Then the key population that we're going to look at, we have 5 reports, 2 indicator, and then we have 3 patient follow-up reports. And then under PrEP, we also have around 5 reports, 1 indicator report and 4 patient follow-up reports. So these are the available reports that you can easily extract from Kenya EMR. So what you need to note that for any system, what you key in is what you get. So for you to get accurate reports, you have to ensure that the data that you capture, the information you capture are correctly captured and saved. So if in any case you don't capture the correct information, you won't get accurate reports. So any form that is available for you to fill for a client, ensure that all the respective fields are filled correctly and saved for you to get accurate reports. Okay, so quickly, let's go through these particular reports. We can start with the indicator reports, that is MOH 731B. So we'll pull the reports and then we see the indicators that are available. It might not be accurate because there are several changes that have happened since yesterday to today. And there are some data that have been changed, some have been added, so they are not complete. So we're just using this for demo purposes for us to know which particular indicators will we have available in our reports. So to start off is MOH 731B. You click on the respective report, it brings you to this particular page where we have the tasks. You can request a report, and then you have the section for summary, whereby all the reports that have been run are listed. Okay, so you can request 1 report. Most entries were done for the month of February. So I'll pull 1 for the month of February. So after specifying the period you want, just click on request and give it time to process. Okay, as you can see, there are several people requesting reports. As you can see, this one has already pulled, so we have we can view the report. We can pull the report in form of CSV, and we can pull the report in a form of Excel. So depending on which one you want to use, we can start by viewing the report for the month of February that I've just pulled. If you click on the view, okay, so the view will give you like a summary of the report with the figures in form of hyperlinks. So when you just take your pointer to any of the figures here, you'll see it changes, meaning that it's a hyperlink. If you click on it, it will take you to that particular, it will give you a list of the clients in that particular indicator. So if you just scroll down, all the reports as they are in the MOH 731B, all the indicators are there. So we can click one of the hyperlinks and see what it has. Let's look at the indicator number 2. When you click on this number 4, it will give you like a it will give you a view of the cohort for that particular, the 4 clients that are listed there in that particular indicator, meaning that you can always go back and look at the entries for that particular client as you can see, the name of the clients are also hyperlinked. So if in any case I click on any of them, I'll be able to open the profile of that particular client and make the necessary changes if in any case there are information that were missing for that particular client. Okay. So if any case all these details were entered, if there are HIV positive clients, they would give you the HIV enrollment date, the ART start date, if they're on ART, if they're done for VL, the last VL, and the date that VL was taken. So that is, and you can also download this particular list, the 4 clients, in an Excel. Okay, so that is all the services you can get under view when you pull your report. That was just a demo. So when you go back, guys are pulling reports. So the server. Which one was our report? February. This one can pull the report in form of CSV or in Excel. So we can pull in Excel and see how does that report looks like the ML731B report for KP. Let me just open this and then reshare my screen. Let me stop and share that report that I have just pulled now so that you see how it looks like. Are you able to see my screen? Hello?
Yes, we are.
Oh, thank you. Thank you so much. So after doing your entries at the end of the month, if you want your report, you just go to the reporting tab as we have demonstrated, and you pull your report. You'll have your summary. This is just a replica of the same report that you've been doing manually. So if you look at the indicators, it gives you the name of the facility or that it's reporting, and then also the period, as you can see. So this report for February 2020, and then now the indicators, depending on how the entries were done. So we have the respective indicators in this report. You can also pull the same from your end and confirm with your hard copy if there's any that is missing. Okay. Yeah, so just to appreciate the work that has gone into coming up with this, to give us easy work. You just click, within seconds, you have your report. This will save a lot of time in terms of tallying, and then also in terms of accuracy, because what you key in, if you do the right entries, then you'll be able to get accurate reports. You can review the reports, and if in any case still you feel that there are some information missing, you can always go back and review the entries, make the necessary changes, and then repull the report again, so that what comes out of your facility is the accurate report that can be used for decision making and give the real picture of what's happening in your facility. Quickly, you can go to the next report. Let me just share the screen for.
Hello, Kennedy.
Yes.
Would you please repeat how we've obtained the report, the 731, the Excel that you've just shown us?
Yes, that is what I'm going to. Just going to that screen. Okay, are we together there?
Yes.
Okay, now let's go back to reports. That's where we are. You go to key population tab to display the available reports that we can get from the EMR, and then we have the under indicator, we have MWH731B. Just click on it, and it takes you to the window whereby you'll be able to specify the period you want to pull the reports. I think it's dragging its feet because several reports are being pulled by users. Okay, there we are. So when you click on MY 731B report, it brings you this particular page. So under task, you click on request report, and then it gives you the dialog box whereby you specify the period for which you want to pull the report. The period can be any that you want to pull report, maybe March. And then you click on request. So after clicking request, it will be processed, and when it's done, it will be listed under finished reports. So it's still under queue. I know there are several reports that are being pulled by users. That is why it's taking that long. Remember when I started, it was very fast. Oh, it's taking time because of the several requests. But that is how to pull the report. Is there any other question apart from that, or any clarification still on how to pull the report so that we continue? If there's none, then we can move to the next report. We look at that report and how it looks like. Let's go back to.
Hello, Kennedy.
Yes.
I have a question.
Yes.
This is Kinley.
Yes, go ahead.
While pulling the report,
yes,
there are some implementing partners that cover different sub-counties, and each sub-county needs its own 731 plus report.
Yes.
How will you go about pulling the report per sub-county?
Pulling per sub-county?
Yes.
All these are like, let me ask about the setup on how the data is being captured. Are you using maybe a single server, or each and every sub-county, they have their own servers to capture patient information?
Oh, good, I can help you on that.
Oh, go ahead, Charlene, thank you.
So yeah, as it stated, the 731 KP report is generated per county. So each sub-county, all the sub-counties are under one dice. Each sub-county has a particular number of hotspots. So that's a request that has been put forward, and probably it will be considered for the next release. But currently in this release, the report is it's one combined report.
Is it clear?
Thank you.
Thank you so much. Okay, the next report, indicator report, that is the monthly report. The same procedure, you click on the monthly report link, it takes us to the Okay, we have the same page where we request the report. Under tasks, click on request report, and then you specify the period for which you want to pull that report. I'm seeing someone has already pulled one. I'm seeing Mali Paris. So it will always show you under the report file name, for which period are you pulling the report, if it's for February, March. So being is the same procedure, I don't know whether I'll be able to pull this one for Mali. It's the same report for the month of February, because okay, it's in the queue. See how it goes. So the same procedure, you can always view the report. You can pull the report in CSV format, you can pull in Excel and ADX. ADX will be able to do the automatic reporting to different platforms, maybe to 3 p.m. You can pull your data from EMR and then push it directly to 3 p.m. if you have your IL configured. So that is also a feature that is available, whereby some indicators can be sent directly from the EMR in form of ADX and pushed to either DHIS or 3 p.m. So that is a service that is available. Let me try to pull this. Just want to see the one that had been pulled by Mali, just to save on time. Okay, let me unshare and reshare. Are you able to see my screen? Okay. For the monthly report, KP monthly report, this is what we'll have. I hope you are able to see. You can, as well, for those who have interacted with this particular report, also can check to see whether all indicators have been captured in this particular EMR extract. So we have the different indicators from indicator 1.6 that is available. We have the indicators from 1.0 to 1.5 that are keyed in manually by the respective partners. I think it's all about the targets, but from 1.6 are being pulled for EMR. So this one, you can easily have it download in the form of ADX that we looked at earlier and send it directly to 3 p.m. So these are the indicators. KP contact all. Under service coverage, we have the KP typology, that is the type of KP, and then we have the gender and then the age, and those who have a non-age. Okay, so depending on what you captured, that is what will be pulled for you from the EMR. So first, before you submit the report, review that it captures all the services you offered and the workload that you had within the period that you are reporting. Okay, so it's just a replica of the hard copy that we've been using. So these are a soft copy that is pulled from EMR. So this will help a lot in terms of timely and accurate reporting. So we have under treatment, the indicators that are being reported. We might not be able to go through them one by one, but if you look at the tab 2, we have sheet 2. It gives you the indicator definitions. So you can always go and review. If in any case you don't understand the indicators that are being reported, you'll always have a description and the source of that particular indicator from the hard copy records in the facility. So these ones will also help you in terms of reviewing your reports, and also when you'll be doing your DQA. So all the indicators the descriptions are here for this particular report, as is in the hard copy. Okay, so you can appreciate what the efforts that are being put in place to make your work easier while doing your reports at the end of every period we are reporting. So is there any question on this report before we go to the patient follow-up reports? If there's none, let me unshare and we share the screen. Can you match screen where we are going to pull the patient follow-up reports? You able to see my screen? Are you able to see my screen? Any response so that we move on?
Yes, we can. I can see your screen.
Yeah. Thank you. This is virtual, you can take your team and you are alone. So I have to confirm through your response. Thank you. So we go back to reports. There are several requests that have been done. That is why the server is dragging and taking long, but it's the same procedure of pulling the reports as they're going to see. Okay, we're back here. Key population, we have the outreach worker summary. You click on the outreach worker summary. There we are. So as usual, you come and request for the report. You specify the period for which we want. There are several requests on the same. So just a quick one. If any case you pull a report for a specific period and you don't see the CSV or Excel sheet, you only see the view. That one means that that report doesn't have data. Okay, there's no data to be displayed, and that is why you'll not be able to see. You'll not be able to see the CSV and Excel options on the queue. So if you only see view, meaning that that particular report doesn't have any data in it. Okay, let me just unshare and reshare the screen. Are you able to see my screen? Okay. So when you pull the outreach worker summary, this is what you get. For those who have interacted with that particular report, you'll appreciate that this one is just a replica of the hard copy report we always do. So this one will give you a line list of summary of the outreach worker in terms of the name of the peer educator. It will give you the number of peers under that particular peer indicator. Remember when we were creating relationships, that is whereby this particular information is being pulled from. So that is why I indicated that for you to get accurate reports, ensure that you also do accurate data entry in the EMR. Okay, so this is a copy of the report that you will get at the end of the month. I hope it's not all that on. Hope you're able to see. So you can identify the name of the peer educator that was created by Bernard, the number of peers under the peer educators, those who received peer education, the condom requirements per month. Those are the information that are being captured by the peer educator. So if any case they were captured, then you'll have just a replica of the hard copy. So just wanted you to appreciate that this particular report is available and you can get it timely and accurately at the end of the month. Is there any question on this report before we look at the next one? The procedure of generating this particular report is the same. Just go to the reports as we've seen. Let me just stop sharing and share the Kenya EMR screen. I hope you're able to see this. As you can see, it's still dragging because of the many requests that have been put in by the users. So it will take time. The procedure is still the same of getting the reports. There we are. So we go to key population. We have looked at the outreach worker summary. Now let's look at the KP cohort register, which is also available in Kenya EMR. There we are. So you can request the report. Just use the same period. Then you request. So let me just share a copy of the report that I downloaded before the system got congested. Let me just share a copy of the report so that you appreciate the KP cohort register. Are you able to see my screen?
Yes, I can see your screen.
Very good. So this is the register with all the indicators. Remember, all the available forms for the KP clients contribute to this particular report. So if in any case you miss to document any service you offer, then you will not be able to get your complete accurate report. So ensure that all the forms that are available and services offered, you capture them accurately for you to get the report. So this is the report with all the indicators. For now, we only have the 2 patients in that particular cohort of February 2020. Okay. So this is the information. You'll get time to just go through the report. And if in case there are any suggestions or any issues, you can always get back to us to make this report better. So for those people who are interacting with these particular reports regularly, I hope it's not new. You just go through to ensure that all the indicators that are needed are captured in this particular electronic fashion. Okay, that is on KP cohort register. So that is all about it. Unless there's any question, then you can we can move on. I'm seeing Paul has raised his hand. Yes, Paul.
Yes, I have a concern.
Yes.
Yes, I've realized now when you update the court register, it's not picking the date of enrollment. But now when you go to and confirm if you already updated the form very well, you find that it's not capturing in the court register. So what might be the problem?
When under date of enrollment.
Yes, under date of enrollment, sure.
Because I'm projecting a copy of the same.
Yes.
So these, if you look at this, it is asking the date of enrollment into HIV.
So it's date of enrollment.
Just a minute.
Okay.
Okay, you're able to see my screen? Is my screen visible?
Yeah.
Okay, so you said that when you capture the date of enrollment, it's not included in this particular cohort.
Yes.
Okay, that is maybe something that you might want to look at. If any case it's the case, then something is going to be done on it. But I believe it's supposed to have, if the date is captured during entries. There's someone taking notes, and that one is going to be looked at. Any other question or concern? If there's none, then let's go to the last report.
Hello,
yes?
Bernard. Okay, Kennedy.
Yes.
The section of unique identifier. It's not capturing the unique identifier. So you can also check that.
Yes. So this one, as I alluded earlier, there are several things that have happened in terms of the data that was that is in the online server. So it might not give you the accurate report. Okay. So this is not like a facility EMR. This is just a test server, online server that they're using. So some of the fields might be missing from it, but that one is noted. Okay, let's move on and look at the last patient follow-up report that we have. Let me just share. Okay, we are back. I hope everyone is able to see my screen. Let's go back to reports, key population, and then we look at the peer tracking register. So the information you capture under the peer tracking form, you can get them in form of a summary. So
Hello.
take time. Let me share a copy of the same report.
Hello, Kennedy.
Yes.
I have a concern.
Yes.
I hope you won't mind if I take you back, because you see, if you could maybe go back to the KP court register, so that maybe we could see whether it captures the sub-county. Because, you know, if the system is not able to generate the MOH 731 plus per sub-county, then it means we will be generating the KP court register, then filtering and doing the filtering using the KP code register to get the report per sub-county. Would you mind going back to the KP code register and maybe try to see if it captures the sub-counties?
Maybe I'll just answer that. Both reports are not generated per sub-county. So for now, I think there will need to be some little of manual process, but we hope that in future versions, we can be able to generate the report per sub-county.
I hope you've noted that.
I think the other bit that is asking is whether on that particular report there is a column for sub-county, so then they can be able to filter.
It's not there. It's not there. So the only thing that they can maybe use to filter are the hotspots. The hotspot is in a particular sub-county. I hope that answers.
Yes, we have the hotspots that can be used for filtering. that report, but that one is has been noted and will be incorporated in the next release with the request that was slotted in sometimes but it's being worked on. Okay, let's look at last copy of the report available for KP, that is peer tracking register. Are you able to see my screen? Any response?
Yes, we can see your screen.
Thank you so much. So this one is a copy of the peer tracking register. Okay, so it will give us the implementing organization, the period for which you pulled the reports, and then a summary of the report. As you can see, this one only has one record. Okay. So the users can appreciate and just try to counter check to see whether all the indicators that are needed for this report are captured correctly. So for the accuracy of the reports will depend on how you capture your data in EMR. So that would be the bottom line, that for you to get accurate reports, as listed here. Okay. So the online server is still up. You can try to go through the respective reports. Other than the KP report, we also have reports for other reports that are available that you can look at your own free time. So I think for reports, that is all we had. Unless there's any more questions or concerns, I'll take it back to Bernard.
Yes, thank you very much, Ken, for that. So I guess we now know how to navigate our way around Kenya EMR generally, but specifically navigating our way through KP module within Kenya EMR. So before we conclude, we are almost done. I just remembered that we forgot a very fundamental step for the client that we had created, and I just thought it is good to really share this. So we needed to check out the client. So when a client comes to the facility, or when you want to start providing services to a particular client, there is a process of checking in. That is when the visit begins. When you are done for that particular day, you check that client out before you move to the next client. So I think we forgot to do that. So I want us to go back to our client and check out. That is one. Then I'm going to also share with you, to get accurate reports, there is need for us to also refresh the reporting database or the reporting table. So I want to show you how to refresh your system so that you get accurate reports all the time. Then lastly, before we go, I think I'll be able to share with you our service desk number, the toll-free service desk number, so that if at all you have any issue, you can always reach out and be assisted with your issue. So first thing first, so let me share my screen and see how we can so I want to believe my screen is visible. So I just want you to go back search for your client. You can click home, come to KP provider, and search for that client that you are created, the last one. Yeah, then you are able to see what I'm seeing. The only thing you need to do is to check out. So I just want to underscore the importance of checking in and checking out. If you don't check out, the system will assume that that visit is still active. So it is always a good idea to check out immediately you are done with the client. You check out that client from the system. That kind of closes that particular encounter. But if you leave it, if you don't check out, the encounter remains open. So let's check out the client. So we just click check out. Then we check out for the same date. Like this one, I'm checking out for 7th February. Then I submit. How many people got an error before we explain what the error is about? Anyone else got an error? Hello? Did anyone get an error while checking out? Okay, silence means nobody has done it.
Yes.
Okay, so this error is simple. When you are doing your encounters, as you are filling these forms, you realize that there are some forms that were filled for 7th February, some were filled for 12th May, some were filled for dates that are beyond 7th February. So when you're checking out, the system is looking back at the last, at the latest date that that any form was filled. So like for this, if you see the 6th May 2020, and I'm checking out for February, then the system gets conflicted, and that's how it is throwing that error. So if you didn't get the error, means you didn't have any form that is not after the date you're checking out. So to correct that, you just check out for the correct date. Like for this one, I want to check out maybe for, that was 12th February, 12th May. So let's go to May. Yep, still, okay. Okay, so I've just checked out with the latest date, but when you are checking in and checking out, it is a seamless process. You'll always be able to check in and check out successfully. Okay, so that is how we bring a closure to an encounter by checking out. Once you check out, then you come up to this corner and close the profile. So you realize that you cannot search for another patient. You cannot search for another client until you close the profile for this client. So there is a close button here at the corner. You just close that, and that takes you back to where you can now search for another client and proceed with your service provision. Okay. The next one, which I want also to, I don't want you to do, but I want you to see, is how to refresh reports. So the system is designed to accept the input from the user, the data that is being entered by the user on different tables. And then the reports are generated from a different set of tables. So in the backend, we could just say that we have a different source for reporting and another one for entering data. So for us to have accurate reports, we have to synchronize the latest data that was captured and refresh it on the reporting side so that our reports could be accurate. So how do we do that? You click home, then you click the ETL admin. Okay, so you click ETL admin, then you simply click refresh. So I don't want to click refresh now, but you simply click refresh and wait for it to finish. Then now you can generate your report. So it is advisable that if the system is actively being used and you want to pull your reports, please refresh the tables before you pull the reports. If you fail to do that, you'll get stale reports. Okay, so I guess that is understood. Last bit is how to contact Palladium for support, especially for KP related support or EMR related support. And I said this is a toll-free line. So if you look at the chat area, I've just posted the number there. Feel free to reach out to us anytime between 8 and 5 every day of the week, Monday to Friday, and you'll be assisted on whichever issue that you have on EMR or on KP. Okay. So I don't know if there is any bit that is remaining.
But you know,
yes.
Maybe just to add on what you said, the number is toll free, so msishtuke ati itawakula credit.
Yeah, it is. Don't flash. Okay, yeah, it's a toll-free line. It's free to call, so just call and you'll be assisted. Thank you, Shalin, for that. Okay, so I don't know if there is anything else remaining. We still have 4 minutes to go. Some issues that maybe I collected during the reporting session. Somebody commented that the KPIF report is the old one. We need to use the revised one, which has additional indicators. So I think that has been noted by the rapporteur, and we will be able to consult with the stakeholders and see whether whatever we have is supposed to be improved on or if it is the same one. The question around, can you review the report generated earlier? This already responded to in the chat. Then there is one where somebody asked whether we could consider adding the PLHIV tracker in the system. I don't know if it was responded to, but if at all it is a requirement, then I think the program will advise accordingly. So up to that point, oh, okay, I also shared the link to the YouTube channel with the recordings for yesterday. So I'm going to download this and upload it in YouTube as well. So if you didn't follow, maybe there's a section that maybe you didn't follow so well, feel free to go to YouTube on our channel and you'll get the video there. Go through it at your own convenient time. And again, as a reminder, for you to receive updates and further additional videos in future, remember to subscribe. Otherwise, I think I want to take this back to NASCOP and for their comment and lead the final session before we call it a day. So Shem, if you are here, you could take it away.
Yes, thank you, Bernard. And thank you for that presentation. And today I'm a happy man because I think at least what we had thought to do, or rather what we had set out to do, we are there now. But to me, what I can say is that we have just scratched the surface. And I think as Ayla communicated in the email, the plan was that we'll have a series of these meetings so that at the end of the day, we are all in the same page as far as EMR is concerned. So I know many of you might still be having many questions. Please don't despair, because we will try to have a series of this. And also, I think Bella has already shared a link to YouTube the recording of this yesterday's meeting as well as of today's meeting. So where probably you still have questions, where probably it wasn't clear, please, you're encouraged to go log into just log into the YouTube channel. It will just be using your bundles, and I'm happy that majority of the dioceses that I've visited have already internet installed. So I think that will not be a major challenge. So I think for me, unless probably if any of you has a question, anyone with a question that is really burning that you think was not responded to, please, this is the opportunity. Anyone who has
I have a
yes,
question,
please.
Shem.
Yes.
This is Kennedy from Mago.
Kennedy, yes.
Yes, I'm asking, okay, on that, disaggregating maybe the court and the MOH 731 plus to various sub-county of our coverage, if it can be done so swiftly, so that maybe in this, by the end of this October, we can start reporting using by assistance of EMR. I think maybe they can give us a date and tell us by the end of this one, it will be ready so that we can start even to do retrospective data entry.
Good question. And then I can take another round of question. I think, if I'm not wrong, that other voice was for Clifford, right?
Yes, Shem. No.
Yes, also proceed.
A lot of thanks to Palladium too for the good job they're doing. Now, there's a question I asked yesterday concerning how do we capture a transfer in and a transfer out negative key population client into the system, and they did promise they would answer it today. Maybe they are still going to answer it. The second question is, you see, we have it's not only one report that we do per sub-county. We have the MOH 731 plus, and we also have the MOH 739C, the FCDRR for key population. Now, from the system, I don't know, but maybe I did not see the FCDRR for key population. It could be it's also in the pipeline among those that are in the pipeline. Maybe they are working on it so that the system will also be able to help us generate the FCDRR per sub-county for key population. Then, another question is on the forms. You see, we have in KP, we do not have the STI screening form. So it means we use the MOH clinic visit form, right?
Yes.
If we screen a client for STI and it happens that the client is positive and the client is diagnosed with an STI, then would it be possible for the system to maybe, if we could have something like a reminder, so that when a client is diagnosed with an STI, then maybe like a reminder that tells the service provider to do the STI treatment form.
Okay.
Then another question is on the PHQ9 and the alcohol abuse screening. Okay, according to the SOP.
I hope Palladium you're writing. Proceed.
According to the SOP, we are supposed to be doing the alcohol abuse screening form and the PHQ9 on a quarterly basis after every 3 months. But the clinic visit form is supposed to be done after every visit. Now, would there be a link or maybe kind of a validation between the PHQ9, the result, depression unlikely, depression ISO, and the depression screening in the clinic visit form, so that just in case a client comes today and maybe we screen the client using the PHQ9 form, then that result is reflected in the clinic visit form, the depression section. Same to alcohol abuse screening form. Then another question is, you see, it is in the peer tracking form where we capture whether a client is dead, ameacha kukua KP kwa sababu maybe hizo. Then the result is reflected or maybe taken to the peer tracking register. Now, is there a link in the system? Is it possible? How does the system now, if maybe from the peer tracking form and peer tracking register, a client is dead? How is it possible for the system to now detect from the peer tracking register that the client is dead so that the system deactivates the client? Or how do we deactivate this client from the system if the client is dead?
Yes.
Thank you.
Thank you. I think we can respond to those. Thank you for your encyclopedia of questions, Clifford. I think if I'm to pick the second tier of the questions, you are suggesting what we call system enhancements, like possible triggers to the system. If maybe a specific field has been filled in a separate way, for example, the way you are trying to do the linkage between the clinic visit form and the STI treatment, for instance. So I think those are system enhancements, and those I believe should be possible. Even if not now, I think Palladium now can prioritize those system enhancements. And to go back to the to Kennedy's question, if the sub-county can, by the end of, if Palladium can actually give us a timeline as to when they can be, the system can be able to auto-generate for all the sub-counties where the programs are reaching out to. Because I think currently the way it is that it only generates one 731. It doesn't go to each sub-county, which I think in itself is a limitation on our side. It limits what we can generate. So I think it would be prudent enough if Palladium can commit to make that one to be sub-county wise. And I think I'm in agreement with the way the team is recommending that we have a timeline for that. And then just to go back to Clifford, you had talked about the MH 739. So two things actually in pipeline. One, the FCDRR that you have talked about, and also our quarterly. Remember, some of you were gracious enough to attend the M&D subcommittee meeting. And what the team ratified was that, the revision of that particular of the quarterly tool. And also it brought forth that through the vodcast that actually was made, the decision was that our quarterly tool equally be reported in each of the sub-counties. So that in itself also needs to be fed into the EMR, so that the EMR can auto-generate. But I think what now I need from Palladium is first to get a timeline as to when the system can generate all the sub-counties for the 731 plus first. Then I think now we can go in a phased out approach to the other 739 and now the quarterly reporting tool. So I think I've tried to answer some of the questions, and I think more.
We have lost Council, you're back.
Hello. Yes, there's a network challenge. So I think we need from Bernard and Charlene, I don't know if both of them are here in this call today. We need by when do you guys think we can have the system generate by each of the sub-county for the 731 plus first?
Hi.
Yes, proceed.
So in as much as it would be a very prudent thing to give like an exact timeline, I think it would be an injustice to the development team, considering that there are other deliverables. So if you can give me a bit of time, I consult so that we know when we can slot that in. Then I can communicate that with you, then you can share with the other team members. I cannot commit to a specific date and time because of other deliverables that are currently being worked on. But for sure, it's something that needs to be considered, and it needs to be part of the improvements that are being put into the system.
Okay. And what about the earlier question about if someone has died, can the system deactivate that individual?
Yeah, I think it was an oversight from Otieno's side. He should have shown the team
Can
members.
I just showed that right away. I think it was we skipped it. I don't know why. If you just give me 1 minute, I share my screen. Yes. Yeah, so I'll still search for my client, Susan Gerubo. So how do we discontinue? We don't call.
Don't know if I'm the only one.
Screen.
You can't see my screen?
No, it's not
We
visible.
can't see your screen.
Not yet.
Okay, proceed. I can see it.
Okay, so I've just looked for my client called Susan Kirubo. So in the system, we don't say, we just say, how do you discontinue that client from the service? So the reason for discontinuation could be so many, not only that. So you come to the section of key population and then you click the discontinue button. So if you discontinue, you state the date of discontinuation, then the reason for discontinuation. So you see that the reasons are so many. You can have transferred out, died, lost to follow-up, cannot afford treatment. If at all this is a paid-up treatment, others and unknown. So the people, the client that is being discontinued because of death, you'll have to specify the death. Then you specify the date that the death was reported. Sorry. Okay. That also goes for transferred out. You can say the facility where they are gone to and the date of the transfer out. Okay. Then lost to follow up. There's nothing else you do. You just save the form. When they cannot afford treatment, the same. There's nothing else you need to do. If at all it is other, there's nothing else you need to do. And then unknown, that's it. So this is where the discontinuation by death also takes place. So you simply click died, date of death, then you enter the form. So the system will discontinue this patient. But one more thing, if you're discontinuing a client due to death, you need to complete this. Once you complete it, you also go back to, I'll not save that because I don't want to kill my patient. You also need to come to the registration to complete the process of reporting the dead. So you come, you edit the information, the basic information, and you come to this section. You come to the deceased section, and now instead of no, you say yes, and then you enter the date of death here as well, and you save. If you do this, the advantage of doing this is that no one will add even a comma or a full stop in that patient's record. The system will lock it so that it is a death case. You don't capture any more records from a dead person. But if you don't do this, the system will keep on reminding you with a yellow alert up somewhere here that this patient is reported as dead, but the process is still not complete. So the system will remind you so that you can come here and actually report that death in the basic information. Yeah, so that's how we do it. That's how we discontinue a client due to death. Thank you. Back to you, Shem.
Okay, so so thank you for that elaborate response and the demonstration. So I think also you know, after I relay the information to all of you, after Palladium has communicated, but we'll try as much as possible to push, you know, to put pressure, because we want the system to make our work easier in terms of reporting, not to do the entry, then again we still struggle to extract reports. I think that is something that we still follow up with Palladium. I'm giving assurance to the team that no stone will remain unturned until we ensure that the system can generate the 731 plus first, before we move on now to the 739 and the quarterly reporting tool. So I'm seeing that Clifford has still typed. He has, I think, dropped a question on the chat box, I guess. And how do we capture a negative key population client who has transferred out from one dice and another and becomes a transfer in another dice? How do we capture a negative key population client who has transferred out from one dice? So currently, maybe to Palladium, does the system offer transfer out of negatives?
Shem, I think I'll want to strategically answer that question, or rather, I'll throw back the question. Is there something like in and transfer out in KP? Because currently, from all the tools you've shared, I have not seen anything that mentions about transfer in and transfer out.
I agree.
Wrong. So maybe it's also something that the program needs to consider moving forward. And what's its advantage in terms of programming?
Okay, I agree, and that yes, we do not have currently any of our tools that captures that, and that the good thing is that they're all here to give ideas on how best. Team, do we introduce a transfer out form? Because usually we don't want to push forms down to you. So do you think, and I want responses from the participants who are logged in here, because they're the M&E experts in this country. So do you, should we introduce a new tool called transfer out form? Then now that we can give to Palladium. Clifford, the raise of the motion.
Sure.
Talk to me.
Thank you so very much. Now, if maybe I can recall, the last time we had a meeting at the Palladium office, Nairobi, there was this suggestion, and I think there was a proposal that I don't know, was it at the enrollment or where they were to maybe introduce a tab for entry, a tab for entry, a transfer in, so that from there we could maybe capture if a client is a transfer in, and then we proceed from there, because currently there is no way we can capture transfer in client. But again, maybe if the team inside here could also agree, do we have a transfer in negative KP client? Because I think Shalina has asked a question. So so that we move together.
Yes, so now, and thank you. So the question is, are we seeing the transfer in terms of the negative clients within our programming? Are we seeing those numbers? Are there people who just come in and say they're from maybe Easter, now they're coming to Hoimas, or they're coming maybe to SOAP, and they're negative, but they're just transferring in? Or for reasons that even if they're positive, they don't want to disclose at that point probably. So they're just coming in and saying that, I got tired of getting services from partner A and I'm coming to partner B. Are we seeing such within our programming? Are the peers really opening up? Or so that now we ensure that the form, because developing it is easy, it's just I think 3 or 4 variables anyway. And we can say that approved by the members who are here today, this is what they're adding as part of the new data collection tool that we're going to use in Kenya. So I think that's not a major decision. The team here is capable, and whatever decision they make here is binding for the country, actually. So I just need first to get consensus from you guys, not just Clifford. Is there merit for us to include a new tool that will just capture, transfer in mostly of the negatives? For those people that are categorically negative and they just want to move from point A to point B. Is there merit for that? Should we proceed to do that?
No.
No.
Chef, what you're asking is that another like one whole day discussion. So I'm not sure if you can answer it in a few minutes. But do we even have chances that all of the people will transfer in will say they've transferred in from program A to here? So to me, that will be actually complicating the program further.
True.
Okay, so Honorable Member of Machakos, Clifford, it seems you did not do your groundwork well. You seem to be losing votes on that one, huh? And because we are very democratic in our processes. Yes.
I have a question and maybe something just to elicit more thoughts. On the, is it the contact form? There's a question that asks if someone is receiving services from another program and you mentioned the program. What was the spirit behind that particular question? And maybe you can leverage on that to just tell you which guys are not like originally from your program. I don't know. It's just something that I've been thinking.
That's a good question. So I think that one actually has been able to stood the test of times. When that question was introduced, I think in the first data collection sets that were made in 2014, the jurisprudence then was that we can, let's say for example, in just within the implementing partner, you have many peer educators, like 20 of them probably in a specific hotspots, and all are trying to do demand creation for a specific dice. So it was possible that maybe one peer educator has managed to make a contact with one peer. They took this peer to the program, wakam enroll. Then on, like, for example, a week or so, another peer educator within the same program comes across this particular peer. So that was, while they were going now to ask that question, even if that person has said yes, the guidance then was that the specific peer educator to still proceed filling the form, to completion. But then when they come to the dice, they can now cross-confirm that I came across this person and this person is 1, 2, 3. Because remember at that time, this particular peer who has been contacted does not have a UIC, because the UIC is being issued at the dice or at the program level. So they just come with that field contact form and then now cross-confirms with the program. Now, in a situation where it was cross-cutting between program A to program B, it was again, our assumption was that the programs will not go ahead to enroll this person if the person has categorically said that they're getting services maybe from partner X. It was therefore incumbent upon that particular program that is trying to get information from this particular peer to reach out to that other program and ask them, within your cohorts, we have come across partner or person X. Kindly confirm if they are still getting services there, because probably now this particular peer is still within our catchment area, and maybe you guys are busy looking for that person. So it was just trying to create a pointer that this is not a new person per se. Yeah, and now to leverage on the working relationships between partners, to be able now to interconnect this person to maybe a specific another peer educator who is coming from another partner, irrespective of whether they're getting services from you or not. So I don't know if I have amicably attempted to answer you, but that was the jurisprudence then, and I think it still holds.
Thanks for that history. So the other question I have then is, do we at the diocese, do we have this particular variable being utilized, or do most KPs come and pose as just new KPs? What is the percentage of KPs who come out and say, yes, I received services from this particular program? I mean, just to
okay, that's a good question, Charlene. But I think at the national level, we have not been able to, we are not able to quantify because that's not a reportable indicator upwards. But I think the programmers here probably can give us a sense of how does it play on the ground. Is it that people, even if they're new, the peer educators will still rename them to, to appear like they have never been contacted anywhere because of the push of numbers? I think, again, the push for numbers, I think we understand. So I think the programmers can share some insights on how well does this boil on the ground. Is it taken as the gospel truth, or is someone trying to play extra intelligent and making everyone to appear new? That, I think, at my level, I might not be able to respond to you because it's not something which we can say we are following at the national level. It's mostly at the implementation. So I don't know if there is anyone within the team here who can try to respond to what Charlene has asked. What proportion, what percentage are we seeing that are still being captured, or rather who have been being seen by other programs? I don't know. Anyone? Hello?
And maybe just to make it even more interesting, is how many partners would be willing to report this, considering the fact that you've said it's a game of numbers, which is not wrong at all. So, like, at the end of the day, we just need to understand and appreciate the nature of the population you're dealing with and the importance of capturing if someone is a TI or a TU, For care and treatment, it makes sense, but for this particular population and the negative KPs, I don't know how much it plays. Maybe the program team can advise.
So I'm seeing Collins Ochola, he has made these submissions, and he is saying that this is something which happens in a blue moon. It's a rare occurrence, and so to me, I think as that we do not labor much on this specific one. Now that members have said the transfer for the negative is not something that we should pursue as of now, and throwing the discussion that the honorable member from Machakos had put forth, I'll say that the EMR, I think right now, when we use it to its, if we use it in its breadth and length, it can now be able to tell us the quantification bit that we are attempting to look out for now. I think it can be able now to bring it to the fore. Because I think it will be more of an anecdotal, but not being able to quantify what proportions. But I think, to me, the advantage of this EMR is that it can now be able to quantify, because at some point I'm thinking that we will not receive any reports if no partner is using an EMR. We will say that that partner does not implement key populations programming. At some point, we'll make that call. So I think for now, we might not be able to quantify as per what you have asked, Charlene, but I think with the use of EMR, I believe we will at some point be able to respond.
Thanks a lot, Shem, for those wise sayings. I think one thing we also need to just appreciate as a KP program is the fact that in as much as there are guys who are already using the treatment EMRs, there are some partners who are pretty new to systems and EMRs. So we also need to appreciate that this is something that will evolve with time. And as time goes by, we will get additional requirements. And the good thing with systems is that when you start using it, that's when you realize that maybe some of the things that are being collected or not being collected are important or not important. So let's take it positively. Let's appreciate the system. Let's go through it inside out, and we appreciate any feedback that is brought back to us. We will sit down as a team, discuss, and see what's the best way forward. Thank you.
Okay, so my other question to Palladium this evening is that this was a navigation training. I think we still need to have a training where you can take the team through generating custom reports. I don't know if that is still within your schedule, and if yes, which time are we having in mind as to when that can happen? Because I know that we are heavy, a heavy driven program. We always have so many requests. So today, the age might be this group. Like for example, right now, our 731 plus doesn't have age category, but over time you might realize that requests are coming in. So I want the team to be very vast in terms of being able to make custom reports directly from the database. So I don't know if that is within schedule or probably that has not been discussed. I don't know. I don't know if you're able to give some timeline as to when we can have that. And then there was this other technical training where we'll go a little bit deeper to discuss about the troubleshooting and issues about installation, the Ubuntu thing and everything. I don't know if you have any thoughts around that, Charlene and your team. Then now we see how best you can move forward. Over.
Thanks, Shem. I think I can let Ben respond to that, but the idea was to have the trainings follow each other. So maybe he can advise on the dates, including the one for custom reports.
Okay, let me respond to the first part of the question, the plans for the technical training. Yes, we have the plan to provide technical training for Kenya EMR and specifically on areas of troubleshooting and installation and general maintenance of the system. But we will need to have, we will need to be very specific on the, well, for the lack of better word, the capacity of the participation of the participant that will need to attend this technical training, because technical training, as the name suggests, and the fact that it is provided through a virtual medium, sometimes is never very easy, especially if the caliber of the participants or the capacity of the participants might not grasp those technical the technical processes that are involved. So I think this is one area I want to really work very closely with Shem and also with all the partners so that we get the participants who will be able to stay with us for the entire course and also be able to grasp the skills so then they can cascade to the rest of their supported facilities and their supported users. So yes, we are having plans for that, but before we hold it, we need to have a side chat with Shem behind the tent. So then we are sure on how we are going to deliver this virtually and what type of participation we'll expect for such a training. Yeah, so having said so, on to the next part of the question for the add-on and customization. We've started some sessions on the Kenya EMR customization. So we've been having this every Thursday with selected participants from across various service delivery partners. So the first group is almost finishing. I think by end of this month we'll be done with them. Then we are going to start again with the second group for another round of trainings from the customization. So I want to really request that we take advantage of that second round, so then we can include most people from the KP partners. So then we can learn how to customize and extend the functionalities of KP as a module and the Kenya EMR in general. That includes reporting as well. Yeah, thank you. Over.
Okay, so this the way you are saying that the second round is starting. Can we at some point are you able to probably to share a link so that now we can also share with our people so that those who have time they can log in. And another question, so currently as it stands, if a partner wants this Ubuntu thing installed, what happens? Who should they call?
Okay, so
I'm asking all the hard questions. I'm asking all the hard questions that my people hear, because I know I don't want them to harass Kyoko or myself. They hear from the horse. Please proceed, Charlie.
As I've stated before, maybe some of you might not have heard this. So our scope as Palladium is to support technical assistance. That's the much we can go. So that means we develop the solution, we train you, then you proceed and support at facility level. So that's why we really need to have a technical training where you're taken through the whole installation process. Then it's these people who've been trained that go back to the facilities and do the installations. So the only challenge with this, and maybe Shem can help me here, is that for most KP programs, they might not have the technical capacity, or rather maybe a technical person who is just set aside to support EMR. So maybe it's also something that the programs might need to have a further discussion and see how best to address this, because currently our mandate ends at training. But again, you can always call the help desk, I believe, and you can be assisted through the installation steps. But it's always good to have that knowledge within the program, just for better support.
I see Diana would like to add on to that. I don't know if you can give Diana a chance to add a voice onto that.
Why not? Diana, please proceed.
I think Charlene has put it well. I really don't for you the same.
Oh,
Diana, we can't hear you.
She's recanting. She's recanting her words.
Can you hear me?
Yes, proceed.
Oh, I'm saying I was raising my hand before Charlene responded, but I think she's put it so well. So like our support will be on TA. So like Otieno said, we are planning technical session. I am not sure of I think we'll work with Shem and the NASCOP team. But I wanted to also chip in on the training that Bernard mentioned about customizations. So the target audience, I'm not sure if he said this, the target audience are software developers. So even as we plan for that training, the target audience are software developers for customization. Over to you, Shem.
Okay, I think then mine first is to the team, because I think from the deliberation which Palladium has brought forth is that we will have another training, but it will be a little bit deeper. And I'll want to, I think I also need guidance from Kyoko here, that we'll need to get to understand who have those extra edge in terms of the feel, not just feeling, but you know, we always feel that we can go to the moon, but those who genuinely feel that you know, they know a little bit of IT that can, because I think it's more intensive in terms of the scope that it will capture. And those, I think, are the ones who will be called upon to support maybe some partners if they're having challenges. So I will need to get a nod, not here, but I think if any of the members who are here in this call today are interested and they feel that they have that extra edge to take them to the next level, I think they can reach out to either myself or Kyoko, and then now we can put together a list. And I think we will also try to interrogate them more. So for those who are interested and they feel they have the edge to go a little bit deeper into discussing about the Ubuntu server, discussing about the kernel, discussing about the backend, you know, which codes can they run? So basically, we will also try to sieve some of you. So please, we want that you guys, you show your interest by either, I'm sure by now, all of you guys, if you don't have my number, you have Kyoko's number. So that now we can be able now to know into this technical meeting. I think that's where now I can say this was this was a morning class. It's like it would be an afternoon class in physics. So those the concentration levels there might be a little bit lower. So we want, you know, a very few guys, because we cannot have a big number. We want few guys who can grasp the entire content and who can run away with it. In terms of, you know, if they're called upon to do installation, when they get to that particular maybe site, if that computer has another issue in terms of maybe it can't boot up, maybe the CMOS setting is wrong, for example, can they troubleshoot that and still leave that site having installed the Ubuntu server? So we want some people who have an extra edge in terms of IT. It can be probably whether you just learn on your own. That's still okay, yeah? So it doesn't really need to be like you have a certificate or a diploma or a degree or a PhD, no. Think maybe through your own hustle, you manage to learn these things. So we need, please, to get interest. Members, please submit your interest in that one, because then now we'll be able now to know who are these that are going to be the technical people that can actually run away with the EMR. I don't know, is that clear, members? Can just someone confirm?
It is clear, Shem.
Yes,
It's clear.
thank you.
Shem, it's clear.
Yes, thank you. So I think please, by COB tomorrow, for all of you who are here, please show your interest. It can be either through myself or through Kyoko. Show your interest that you know, this, you are interested in this, and that we will call you, try to get to understand your standpoint, where you're coming from. Please, I know we are Kenyans, we like volunteering, but this is it's like diving to the deep waters, yeah? So at some point, you might be left behind if you are staggering. So for that, I just need the ones who are ready to do scuba diving. So I think at that point, unless my senior colleague, my senior counsel, Japhet Kioko, has anything to senior counsel, Japhet Kioko.
Yes, Shem.
I don't know if you have any words of wisdom.
Sorry, I think you have covered much of what we may want to have discussed after the training. And so like the issue of the technical training, I agree that probably members may want to come up and show interest, and probably we may also want to look at the regional kind of composition, so that then, because the team may not be that big, and we have teams who can be able to support the different areas where the key population implementation takes place, or where we have interventions. And my other thing, I think I came a bit late, Shem. There was a question yesterday. I don't know whether it was responded today, but there was a question, because like HEMPEG have been asking about transition of their data to the Kenya EMR. And I think that point was raised yesterday. And sorry for taking you back, you might have covered that. But I wanted to know what was agreed upon, probably in our discussions today. Will it be like, will the partners do entry retrospectively, or there would be a mechanism of sharing the data? But otherwise, I think at this point I would stop at that. Thank you.
So thank you, Kyoko. And back to Palladium. I think Palladium, and I have had Palladium speak in some circles that they are going to move. Okay, the current migration is happening, and they have a script for that in terms of migrating people from IQ Care to now the Kenya EMR. But I don't know if they have a script that can migrate people from Excel-based, or with, or maybe they can give us some sort of a data dictionary, that if a data is in this dictionary format, then we can be able to move you. So back to Palladium.
Yeah, you are right, Shem. We are currently supporting migrations, but the type of migration that we are supporting is slightly different. That is IQ Care to Kenya EMR. And IQ Care and Kenya EMR are two systems that Palladium were developing and supporting. So that migration was a Palladium activity. So for the KP, I know different partners have different systems. So for the migration, there are two types of migration in this case. There is one, the 11 facilities that were pilot sites that were using KPS now to the integrated Kenya EMR that has a KP already in Kenya EMR. So Palladium will be supporting that. But now the other migration from the different systems that partners have to Kenya EMR, it's something that will not be supporting, but will be offering, actually will be offering the TA, if you have any technical people from those organizations who understand those systems better, technical support to actually do the migration. But Palladium will be supporting the KPS to Kenya EMR. But for the other system, I will be providing technical assistance to the tech team from the different organizations. Over.
Thank you, Diana. So I was asking, so that technical assistance will be on need basis. Like if MPEG will request you to do the TA to transition their data, or there will be a plan in terms of capacity building, or it will be offered during the technical meeting.
Yeah, so it would be easier. Yeah, like you said, it will be case by case, but the organization that has the system is the organization that understands that system. And since Palladium do not understand that system, the only technical support is with the tech team to just show them how the data will get into Kenya EMR, like the Kenya EMR structure, so that they can migrate that data to Kenya EMR, but not really the actual migration, because the tech team for those organizations that develop the system would understand how the system is better than Palladium team. Over. I'm not sure if you got me.
Yes, thanks, Diana. So sorry I was muted. I got you right, and I hope the likes of Caro are here and everybody, so they have heard, and so they should be able to take that to the next level in terms of probably getting the right support in terms of technical assistance to do the migration. So thank you. I hand over back to you. Shem seems to have, I don't know whether Shem is still in the meeting, but I would ask if there is any pending issue or question, probably from the members as we conclude. I can see time is not on our side. So if there is any last question from any quarter, I think we can raise it so that if Palladium or RASCOP can respond, then we can conclude the meeting. And I do hope we have the next steps in terms of what we need to do, because I think most of us have been implementing and have been using the EMR. So probably this training should be an added advantage to you in terms of ensuring that all the data is in the Kenya EMR in terms of entry, and also ensuring that the retrospective data is also entered or probably transitioned to the Kenya EMR. Any question, any pending question, any final thoughts? So in the absence of any question from anybody, I think I would assume that we are okay, especially for this level 1 training. And Shem had said, let's get the interested people for the second round of training, which will be the technical training. And so from there, probably we'll be able to see whom to include, because as you have heard from the Palladium team, that it'll be highly technical. So probably share your interest and then we'll take it over from there. And at this point, I think I'll thank everyone. I will take the opportunity to thank Palladium for taking their time, the 2 days to take us through the system. I'm sure we have learned quite a lot. Many of us, or some of us, might not have been quite familiar with the system. And even if some of us were familiar, probably this has also added knowledge in terms of how to navigate through the system. So thanks a lot, the Palladium team, Charlene, Bernard, Diana, and the Palladium team in general. And also thanks to the partners who have been able to attend this training for the last 2 days. We do realize that it's not by chance, or rather, we don't take it for granted that you were able to commit your time to join the training. And we are sure that this training was quite useful in terms of moving the agenda forward. So thanks everyone. And I would close this meeting at this point in time in the absence of any more questions. So thanks everyone, and bye.
Bye.
Yoko, have a good evening, everyone.
Bye.
Bye.